Very much, Steve, and thanks to Dr. Nigel Bedford for giving me this opportunity to present this new update, new updated multimodal practical solution for the problem of the wrong-sided block. In order to achieve compliance with the Stop Before You block, the Safe Anesthesialization Group created in 2021 this new updated process that I will go through now. As you know, wrong-sided block may carry a lot of problems to patients and to our organization. It can cause risk or potential risk of complication from unnecessary block, and such as nerve injuries or local anesthesia systemic toxicity, or even local anesthetic overdose. Sometimes hospital discharge may be delayed because of reduced mobility. Also, at worst, it may cause wrong side surgery if the team continue on the same side, the same wrong side of the block. All this may create a lack of confidence in the healthcare system, and so we needed to search for a solution. And in order to understand it, there is a predisposing factors for this serious event, which can be classified into either distraction in the operating room, either from rushing or during teaching, or during a change of patient positioning, or miscommunication, or due to delay between the WHO sign-in time and the time of performing the nerve block. For example, if a patient receives spinal anesthesia and then we are giving him a lower limb block after difficult or time-consuming spinal, these are the causes that lead to the problem of the wrong-sided block, and so we usually need to be vigilant, especially during if there is a long duration of primary anesthetic, either regional or general. We need to give be more vigilant if we turn the patient position, or if we change the block size, like if we are doing ankle block and we are changing the leg position, or if we change the patient position from lateral to prone, or from if there is any, in case of busy anesthetic room, we need to be be more cautious. And however, with all this, a problem continue to occur, and going briefly through the history of the Stop Before block, I want to say that since 2010, and there is a number of safety initiatives that have been implemented, focusing on reducing this problem. Started from 2009, when NHS introduced the never event framework, and then included the wrong side of the block in 2015 to be one of the never events. And the never events is defined as the serious events that should be preventable, and this should be preventable based on that we have guidelines, our national guidance, that if it was implemented well, this event should be preventable. And in 2010, the Safe Anesthesialization Group published an alert highlighting details and learning points from 67 inadvertent wrong-sided nerve block reported over 15 months. And the recommendation from this alert was to check that the surgical site had been marked by the surgical team before performing any peripheral nerve block, as per the WHO checklist. And in Nottingham, in 2011, because of the incident of 5 reported wrong-sided block cases over 12 months. The analysis revealed that in all of these cases, the surgical site had been marked appropriately, and WHO sign-in was performed correctly. And so the process of stop before block started here. It was an innovation by the NUH and has been adopted nationally. And the process involves the post moment just before the block is done. And this process is was used to be a dual responsibility of the anesthetist and their assistant. And the problem, despite of this, continue to persist in spite of this national guidance. And because of this error continue to occur, what was the problem with the original stop before block process? In fact, one problem was that while the original poster that I showed earlier stated that the stop moment should have been done immediately before needle insertion, and that the site should be recognized with a surgical mark. The later research indicated that this was widely misinterpreted, and there was a lot of variation between different trusts in implementation of the stop before you block. And so the recommendation, also the recommendation that the anesthetist and his assistant should check together the mark and the consent was usually overlooked. And the people believe that they are doing stop before block. However, it was not done appropriately or universally the same over the UK. And it was unclear whether the stop before block in its previous form has had any impact on the incidence of the wrong-sided block or not. Also, there was no consistent approach to training and supervision of the stop before block in anesthetic training. And also, there was, as I said, there was individual hospitals and individual anesthetist has interpreted the process differently, and so this local variation was confusing for the rotating clinicians, the trainees, and the locums and also it was difficult to map the adverse effects against a consistent framework. That's why in 2018, Hoping et al. Have surveyed UK anesthetists, and the important finding in this was that while most anesthetists believe they perform the stop before block, in fact they perform it in a moment too early than it should be, the stop moment. That's why in 2018 the Healthcare Safety Investigation Branch asks for standardization of the process over the UK. After they investigated the causes of wrong-sided blocks, they invited the Safe Anaesthesia Liaison Group to formulate a standard national policy. And so, because we have the need to assemble a standard process, and in order to reduce variation and reduce reliance on memory and vigilance, in 2021, the new concept of prep stop block came. While we will maintain the catchy title of stop before you block, we will implement only the updated universal national guidance. And what is the difference in the new process is that it should be, we will have a SOB which should be applied nationally, and we will maintain the brand stop before we block, and we will now can map the all the incidents against the SOB. So it will help with investigating the causes, with improving the process, and measuring the implementation of the stop before you block. And to achieve this, we have a training package consists of this poster, the PrEP stop block poster, and a video, and a training video, and a stop and an SOB. I will go through the video now. Before going to the video and the SOB, I just want to highlight that two things: that the preparation stage should be done by the anesthetist, which is called blocker, and his assistant, and the blocker will hand the tray of the drugs and the needle to his assistant, to be away from his hand, away from his catch. Then he will scan and adjust the position of the patient, and then he will be ready for the stop moment. I will we have this magnificent video done by Dr. Del.
Stop before you block is a safety recommendation that should be used by all staff involved in the placement of peripheral nerve blocks which involve laterality. When performed correctly, stop before you block is a strong preventative measure to avert wrong side blocks, which are an NHS improvement never event. However, stop before you block is often inconsistently applied, so the Safe Anaesthesia Liaison Group have reviewed and updated the guidance. Stop before you block is now a 3-step process. Step 1 is prep. Step 2 is stop. And step 3 is block. Step 1, prep. On arrival of the patient into the anaesthetic room, block room, or operating theatre, the WHO sign-in is performed, which should include confirmation of your patient's identity, confirmation of the operative consent form, and confirmation that the correct operative site has been marked. The blocker draws up the local anaesthetic and places the labelled syringe along with a suitable nerve block needle on a dedicated tray or container separate to the intravenous drugs. This tray is then handed to the assistant, out of the blocker's immediate reach. The blocker and the assistant should now position the patient and the equipment in the final position ready for the block. Where necessary for conduct of the block, any dressings or plaster casts should be removed. A pre-scan ultrasound might be undertaken at this stage. The blocker should now clean and prepare the site ready for the block. Step 2, stop. The stop moment is a 2-person step that happens only after preparation is complete, and thus immediately before needle insertion. When the blocker is ready, the blocker formally announces to the assistant, "I have completed my prep, let's stop before you block." The assistant should reply, "Okay, let's stop before you block." The blocker and the assistant together should then check the block side by viewing the surgical site mark and verbally confirming the correct side. The assistant reconciles this with the consent form. If the patient is awake and unsedated, they may also confirm the side is correct. Step 3, block. Only when the correct side is confirmed does the assistant hand back the tray to the blocker. The blocker immediately performs the block. Any delay between handing back the tray and performing the block should require the blocker and the assistant to restart the stop before you block process at step 1. This video has been produced with reference to the common context of a single peripheral nerve block. There are numerous other contexts where nerve block or local infiltration injections are undertaken, and guidance for these other scenarios can be found within the standard operating procedure document.
As I mentioned, the training package of the stop before you block in its new update, pre-stop block, consists of the poster and this teaching video and the SOB. And because previously the stop before you block was had a lot of variations among trusts. There was more than 25 plus interpretation of the stop before you block process. So the main aim of this new SOB is to replace the existing failed policies of the implementation of the stop before you block. So this SOB is considered a national standardization of the process, and it is considered a detailed description of the pre-stop block. And I just want to highlight that we need to hand over the tray to the engaged assistant and to take it back from him after we do the stop moment. And with this SOB also suggests some words to trigger the SOB moments, like the blocker will say, "I have completed my preparation. Let's start. Let's stop before you block." And the assistant should reply, "Okay, let's stop before you block." And the aim is to generate a forcing moment or a forcing function or behavior shaped constraint from proceeding to the wrong-sided block. And in fact, this SOB will help us map any future incident against this reference SOB. And there is some special situations, like they'll mention in the video, when we have a sterile field and we cannot hand over the tray. In this situation, the SOB clearly stated that special vigilance need to be taken between the blocker and the assistant. In case of we had multiple blocks at separate sites, in that situation, we will, there is a risk of wrong side block, as I mentioned, with changing position. So we need to do the pre-stop block moment for each block. And also in case of multiple injection at the same site, like in ankle block, this risk assessment should be for the anesthetist or the blocker who will perform if there is no change of position. So one pre-stop block moment can be enough. If there will be a change in position, the pre-stop block should be repeated. Also, in case there is multiple surgical marks for complex surgeries, we need to have more extra communication and vigilance between the blocker and his assistant. And during teaching, also this was noted that teaching sometimes causes distraction. So who will be the blocker, the consultant or the trainee? In fact, the responsible supervisor will be the blocker. However, we need to encourage the trainee to lead the process of pre-stop block. And also, in case of doing the block outside the theater, like in resus, and there is no surgical mark, the SOB stated that we need to discuss this with the patient, engage the patient, and we can have an anesthetic mark, which is not normally recommended to avoid the confusion between the anesthetic mark and surgical mark. And we need to pay extra care during these situations. If we are doing the block after the surgery and there is no more, there's no surgical mark at that time, that we can, the SOB stated that the surgical site will be verifiable, and because it is evident, and we can proceed even there is no surgical mark and no need also for the anesthetic mark at that time. So what will be the next steps? In fact, there is now we are trying this block tray, this color-coded block tray. We are assessing its use. We use it as an educational, extra educational step for to raise awareness regarding the updated prep stop block technique, because it carries all the instruction and it carries a poster on it, and we need to spread this poster. And regarding the implementation of the prep stop block in UH, we would need the engagement of all members of the anesthetic team, the anesthetists, the ODPs. Their engagement is successful to launch this update. And we have the resources, which is the SOB, the new SOB, and the new poster and the new video. We need to keep these posters everywhere and in each place where the block is done, and we can run the videos, the silent one on the screens, just to raise awareness about the prep stop block update. And I want to take this opportunity to ask you to be leaders in implementing this national guidance, and I ask you to adopt all the measures that raise the staff awareness and to communicate this prep stop block update with all members of the team. And in summary, I don't know if I'm running out of time, but I want to say that there is no physical intervention that was proven to absolutely prevent the wrong-sided block. However, I think this well-designed, this SOB, if used properly by everyone, will be the next best thing. And if its effective implementation will require all team engagement and education, and finally, I think we can conclude that considerable work will still be needed to achieve full compliance with the prep stop block update at the correct time and at the meantime. And thank you.